Welcome to the show, Healthcare from the Hill. I'm Dr. Amit Lahav, your host, and in this show we discuss medical-related issues and topics. Today we're going to discuss back pain. How many of you Americans out there have had back pain? It's the number one reason why individuals seek medical attention and orthopedic evaluation for back pain. There's more loss of working days in the workforce because of back pain, more injuries because of back pain and the loss of work accordingly. We're going to discuss specifically your lower back pain, and we're also going to get a perspective from a neuroradiologist on back pain. Today we have with us Dr. Vito Errico, who will also discuss the perspective of back pain from a neuroradiologist point of view. Stay tuned. I'm Dr. Amit Lahav. We'll be right back for Healthcare from the Hill, and we'll discuss back pain. Welcome back to Healthcare from the Hill. I'm Dr. Amit Lahav, and today with us we have Dr. Vito Errico. We will be discussing back pain. And what I'd like to concentrate actually is on your lower back. And if you look at a model of your lower back, this is your vertebral column here, and this is your sacrum here. This is what attaches to the pelvis. And this is the area where we're going to be discussing back pain, essentially lower back pain. I'd like to actually go to the presentation just to go over some reasons for back pain. If we can go to the presentation, please. So we'll discuss back pain, really your lower back, because essentially back pain can be from your upper back to your lower back, but specifically we're really going to concentrate on the lower back region, which is considered your lumbar spine. Back pain is a common complaint. Most people in the United States will experience low back pain at least once during their lives. Back pain is one of the most common reasons people go to the doctor or miss work. And if you look at here, this is essentially your vertebral column from the cervical down to the sacral spine. Cervical is your neck region, thoracic is where your ribs meet, and then your lumbar, which we're going to concentrate on, is the area of low back pain. Down below is the sacral region, which is where your pelvis meets your spine, which has much less reasons for injuries or pain. Let's go through some statistics. There are some studies that actually show that current smokers was associated with increased prevalence of low back pain in the past month, low back pain in the past 12 months, seeking care for low back pain, chronic back pain, and disabling low back pain. Former smokers had a higher prevalence of low back pain compared with those who never smoked before. Another statistic is back pain affects about 8 out of 10 individuals at some point during their lives. Another point is that approximately 1/4 of the United States adults reported having low back pain lasting at least one whole day in the past 3 months, and close to 8% reported at least one episode of severe acute low back pain within 1 year period. Another point is, when asked about common types of pain experienced in the past 3 months, respondents of a National Institute of Health Statistics survey indicated that low back pain was the most common, 28%, followed by other issues such as headache or migraine pain, as well as neck pain. What are some of the causes of back pain? Let's break it down. Muscle ligament strain, herniated discs, arthritis, skeletal irregularities, and osteoporosis are some of the big ones. Muscle ligament strain essentially is repeated heavy lifting or a sudden awkward movement that can result in strain of the back muscles as well as the spinal ligaments. Herniated discs, the discs acts as cushions between the individual bones, which are called vertebrae, in your spine. And sometimes the soft material inside the disc may bulge out or actually place pressure on the nerve or roots coming from the spine. And this is actually very important because patients present differently than just having low back pain. What about arthritis? Arthritis can affect the lower back, and it's actually very common as you get older. In some instances, arthritis in the spine can lead to narrowing of the space around the spinal cord, leading to a condition called spinal stenosis, which we will also discuss. What about skeletal irregularities? Back pain can occur if your spine has curves in an abnormal way, not just necessarily scoliosis, but things like kyphosis. And osteoporosis, compression fractures of the spine can also occur and can lead to fairly disabling low back pain, which we will discuss with Dr. Arrico, perhaps some of the procedures that can be done for compression fractures, which is seen really in the elderly or osteoporotic type of bone. What are some of the symptoms and types? Well, back pain symptoms can range in intensity from mild to actually very severe. Sciatica type of symptoms can cause pain in the lower back and the legs. It generally travels down your legs and usually in the back part of your leg. Low back strain, one of the main common causes of back pain, whether acute or chronic, is also what we consider mechanical back pain, generally situated really just in the lower back. Spinal stenosis, which I just mentioned, it's pain with increased activity or what you may feel like heaviness in your legs or thighs. Compression fractures can be localized back pain depending where the fracture is, but the lumbar spine or your low back is a very common area for compression fractures. Disc herniations. This is important because it can present with neurologic deficits, and this is where we sometimes consider surgical intervention. And something I want to mention is also nighttime back pain. Nighttime back pain is a special type of lower back pain which can also indicate a serious problem with your spine and can include things like tumors or multiple myeloma. So this is one of the questions that's important to ask if you have pain just with activities during the day or even at night. Does it wake you up from sleeping? If you're looking again at the spine here, you break it down. The vertebrae are the blocks that form your lower back. The discs are the cushions in between, but then there's ligaments and muscles that help hold it together. And the nerves come out actually out of every level. And I'll go over a model with you to show every level there's a nerve root that comes out that supplies innervation down to your legs. Example of disc problems are disc herniations or disc desiccation, or where the disc essentially dries out and you have loss of disc space. You can also lose mobility. And if you look at the upper right side, this shows what a disc is, and it consists of two things, the annulus and the nucleus pulposus, which can herniate and actually put a pressure on a nerve. So if we go to the next slide, you can see here a diseased vertebral disc which can place some pressure on the nerve root as it exits from the side. On the right side is an MRI, and the lower part of the MRI shows the nerve roots, which looks like small little dots with sort of a whitish fluid around it, which is synovial fluid. And this is what normal looks like when there is a disc herniation. That synovial fluid essentially disappears when there is pressure or mechanical pressure on the nerve roots. On this next slide, it shows an MRI of a normal disc and also of a herniated disc. The normal disc is on the left side, and it's also showing the nerve roots, which are labeled here. The disc is between the vertebrae. It's not pushing on any nerves. But on the right side, there is a disc herniation, which I'm showing here. That's a herniated disc that's coming out of place, and it's going to put some pressure on the nerve roots. If we go on to the next slide, this is a little bit more on spinal stenosis. This can be secondary to a disc herniation or degeneration or arthritis, which essentially cause narrowing of the spinal canal and putting pressure on the nerve roots. This can cause sort of heaviness in your legs. Sometimes the patient presents with a feeling of they're able to walk for a certain distance and then they have to stop. They stop for a couple of minutes and they're able to walk again, and it just repeats over and over. Compression fractures. Again, we'll speak with Dr. Arrico as well, who's a specialist in this type of treatment from a neuroradiologist perspective. Compression fractures when you have the vertebra essentially crush. And I can show you here an MRI on the upper right side. This is an MRI or that shows that actually there's a compression of the vertebra. Next slide. Spondylolisthesis. This is a slip that occurs in your vertebrae. So one vertebrae slips compared to the other. Slipping between level 4 and 5 of the lumbar spine is actually degenerative and commonly seen. And there's different grades of a slip, anywhere between 1 all the way to 5. Where 5, the vertebrae is actually slipped completely off and can even cause things like paralysis for the lower extremities. So this is something that's being able to be picked up on radiographs like X-rays and CAT scan. It is important to also grade it and determine if that is a cause of pain. Sometimes what we do is we take a look at the individual, and we sometimes describe this almost like a bubble butt, because even a young, healthy individual can have this problem, and it's almost like the butt is sticking out more than usual. And that can signify actually a slip. She or he may not have pain at the time, but if you get the X-ray, this can be progressive, and it's something that it's important to diagnose earlier on. Here in the spondylolisthesis, or the slip, when a slip occurs, you can see that the nerve, which is the yellow structure there, can get impinged and can suffer, and you can actually lose motor and have weakness and motor function difficulties in your lower extremities. And if it's pretty severe, it can actually impinge on multiple nerve roots, which is why this can cause paralysis at very severe type of slippages. For this, sometimes we do proceed with surgical intervention where we actually have to fuse your lower back. Now, in this segment of our show today, we're not going to go specifically on the surgical treatment of lower back, because that's a whole topic within itself. But I want you to know that some of these do lead to surgical treatments where you have to put hardware, which is shown here as the white. It's metal screws and rods to kind of keep the spine where it's supposed to be. But most of the time, low back pain is usually mechanical back pain. And mechanical back pain essentially leads to irritation of the muscles or the ligaments. And there's a problem with your lower back musculature. And a lot of times, exercise is really the key. And that can make a big difference of how you feel. But what's important here is also maintenance of the exercises. So I'd like to kind of go back right into the discussion. And I'd like to welcome again Dr. Vito Rico, neuroradiologist in Milford. Dr. Rico, we've had you before on the show here, and I think it's been very helpful kind of to hear from the neuroradiologist perspective. And this topic, back pain, is very big, and that's part of your specialty. So well, thank you for coming.
Well, thank you for having me on the show. Yes, like you had mentioned in the beginning, the number one reason for people to stay home from work is back pain, and that was when I was studying in medical school. I think it's still the same statistic.
Absolutely.
So, there are some treatment options both on the surgical end of things and also on a radiological end of things, where we use X-ray or CAT scan to guide us into treatment of some of these ailments in the back.
Well, before we actually even jump into that, once we get a little bit of background, what do you do as a neuroradiologist?
Okay, so neuroradiology is basically a subspecialty of radiology. So radiology is the general residency you do after medical school. And then you can subspecialize, and one of the fields is neuroradiology. And what I do as a neuroradiologist, besides reading MRIs of the brain and spine, and since I'm in a general practice, everything, basically mammography, ultrasound, and CAT scan. But within neuroradiology, there are some procedures we can perform that will aid in diagnosing back pain and its origin, as well as treating the back pain. So not only, it's like what I call one-stop shopping. You get the imaging, you discuss it with the patient, you see where the pain is, going, and then you're able to treat.
And really, the treatment a lot of times also involves things like injections. And there's different type of injections that you perform.
Right.
And we're not talking about things like spinal fusion or disc herniation, discectomy type of surgeries.
I'll make that clear. Basically, although vertebroplasty, which I'll get into, which is helping compression fractures by putting a cement, that's considered sort of back surgery. But beyond that, I don't, remove discs or do what we call laminectomies to decompress the spine. What we do is relatively non-invasive injections of steroid into the spinal canal to help soothe the inflamed nerves. So that's where I come in to do those kind of things. But it's really not considered back surgery.
But it's important because it treats pain.
Right.
And if you have no pain, then you wouldn't have no problem.
Right.
But when you come in, is if you treat that pain and the patient is happier, then that's where neuroradiologist takes really a front row seat.
Right. And what I like about doing it under neuroradiological ways is that we're able to look at the film and then diagnose it, and actually under fluoroscopy, on the live fluoroscopy, you're safer in putting the needle into place versus just blindly injecting.
So I'd like to start first because I do actually refer patients to you specifically for those reasons. And I'd like to start first with kind of the mechanical low back pain, which is the most common type of back pain. And that's a patient that comes in that really was no particular trauma, or maybe there was some lifting or increased activity that was done, and they present with lower back pain. And one of the most important questions that I ask is, do you feel anything down your legs? Is there any numbness? Is there any weakness? Because that can signify a difference between things like disc herniation or spondylolisthesis or sometimes spinal stenosis versus just mechanical or low back pain, which is more of a strain. It's just localized to the lower muscles of your back and sometimes the ligaments. And most of the time that's treated conservatively with things like anti-inflammatory medications. If you have a spasm, you can have a muscle relaxant. Sometimes we also use oral steroids like prednisone to really treat a very acute type of symptoms in back pain, because some of this back pain is very disabling. You can even wake up or do some movement and you essentially lie on the floor. You can't move at all. And that's pretty severe back pain, which is disabling. But again, most of this back pain will get better with conservative management. And just to give even some statistics, when you have sort of this low back, mechanical back pain, if you kind of look at a 3 months period, even if you do nothing about it and just essentially just suck it up, about 80 to 90% of patients get better on their own. It gets better. But it's about 3 months' time that you have to ask. And you have to wait, really. And what we ask is, well, do you want to do something earlier? Do you want to try to get better earlier? And we try to kind of expedite as an orthopedic surgeon, as a neuroradiologist like Dr. Arrico, and even as your primary care physician. There are things that we can try to do to kind of get you better faster. But what's important afterwards, also maintenance of keeping you healthier and not having these recurrent type of episodes. Because if you do have these recur more often, then you are more susceptible to actually have it occur more and more often, which becomes more of a chronic problem and a more disabling problem really in the long run. And I think that's very important.
And yeah, it is, and that's a good point. I mean, what the 3 month period that they get better, what we try to do with epidural injections with steroid is try to break that cycle of pain. And some, in a subset of patients that does happen, where you just break that chain of pain and inflammation.
Exactly. And so if really the conservative management initially doesn't work and you try the anti-inflammatory medication and the muscle relax and you're doing some exercises, you have this sort of persistent problem, your posture now has changed. That's when we consider things like injections. And it's not always an epidural injection. It could be also things like facet injections, which are really the joints in the spine, but not the vertebra, that also gives some of that mobility and can be a source of pain. And if I really go again into a model here of your lower back, if we can zoom on this a little bit, your facet joints are actually in the back here. And what happens is that they get irritation. They can cause pain in the lower back region. So injections, even directed in this area, can essentially break that cycle like Dr. Arrico was describing and give you some relief. It doesn't go into your spinal canal. And just to show the difference, here, if you look at this model here, there is a cord or nerve roots that are inside, and you can see there the yellow here. And out of every level, there is a nerve root that comes out. shown yellow here as well. And these type of facet injections, are not targeted at the nerve roots. They're targeted more at the joints of the spine, what we call the facet joints. Epidural type of injections, and I'm sure Dr. Rico will describe that as well, really go more into the epidural space, which is where near the nerve roots or the cord, if you actually work higher than the lumbar level, that gives relief of pressure in that region. And also to break it down, I have a larger model here showing essentially your cervical spine up on top, thoracic spine here, and then your lumbar spine at the very bottom. And I want to see if we can actually show this. There's actually a little red mark right there that shows a disc herniation. It's pushing pressure on one of the nerve roots. And that's a disc herniation, which again is different from mechanical low back pain. That's a mechanical pressure on the nerve root, where an epidural or foraminal type of injection, which we'll go into a little more detail, can relieve that pressure on the nerve root. So essentially it doesn't necessitate you having surgery, but can relieve that pressure, and you may feel good even with conservative managements such as injections. So really for a patient who has mechanical back pain or a strain of the back, when it becomes more chronic or persistent, we do send them for injection also. And a lot of times you actually like to get an imaging study beforehand, not just having an x-ray.
Right. You know, oftentimes when they're sent to me and you appropriately get the MRI before, I can put together the patient's symptoms with what pathology they may have in the spine. So if, you know, we often refer to what's called dermatome distribution maps to see if they have the leg pain is in the front or in the back. It's a different nerve that is probably compressed. So that's why we look at the MRI, put it together with the patient's symptoms, and then inject at that appropriate level.
So having really further imaging is important because it can also, number one, differentiate between things like disc herniation or other slippage in your back or even sort of more pronounced arthritis in the back versus an imaging that looks pretty normal, but you have essentially just irritation. So it actually helps you guide where you give these injections.
Yes, it does.
And again, the injections for, let's say, facet injections are different than giving an epidural or foraminal injection.
Right. The injection material is still the same. It's basically depomedrol, which is a type of cortisone, and bupivacaine, which is a longer-lasting Novocaine that you get at the dentist's office. So you put that combination, but in a different spot. If a facet is affected and he's got localized back pain over that facet, or facetogenic pain we call it, then most likely they would benefit from an injection directly there.
So it's a very localized injection that you do, which again, why imaging is important for you.
Right. I've been also investigating some trigger point injections because not only does it give branches off of the disc to the facet also gives some branches to the local muscles, and they get irritated, and you want to break that cycle. And sometimes just injecting into the muscle and breaking that up with some bupivacaine or steroid will help the localized back pain.
And that's something that actually professionals like acupuncturists also discuss and sometimes work that way, or some a chiropractor type of individuals also treat kind of trigger point.
Right. It's something I've been investigating more because in medicine you have to have a little bit of an open mind. You don't just, you don't just do what you think is just medical. You have to put it together with, muscular and skeletal and see where the pain is derived, and maybe those things may help actually.
So you got to take on an overall evaluation, taking the history of the patient, the physical exam, the imaging.
That's why the imaging is important, because if all of this is from a compression fracture, a fracture of the spine, and you're going in and getting that manipulated somehow, that could be a problem. So the imaging is important, and you have to put it together. If that's all fine and the muscles look like they're tense from a facet problem, then you could suggest maybe some manipulation or even massage therapy locally.
All right, so you have to actually really treat the right diagnosis.
Yes.
And really, according to the American Academy of Orthopedic Surgeons, generally patients who come in with back pain, suggestion for x-ray is not made until about 6 weeks after they have the back pain, which most of us don't always do, because we want to make sure we rule out other reasons. 6 weeks is a big period of time. If it really appears mechanical and everything else, neurologic exam feels normal, then it's perfectly reasonable to treat it as sort of low back strain. But if there's something else that just feels a little bit different, we always like to get an imaging because you don't want to miss anything which can be picked up, even things like spondylolisthesis, a slip between the vertebrae as we discussed, or a compression fracture in an older individual as well. And I've seen that even from an elderly lady who was just actually moving her mattress.
Yes.
And she ended up having back pain, and it wasn't a strain, it was a compression fracture.
Well, we see the gamut from you really dwell into the history and they really say, I don't remember really doing anything. And more times than not, you'll find something that they've done. Like in the spring, what I see a lot of when they're opening up their windows,
Right.
from being all locked up in the winter, and that sudden little jolt can, especially if you have weak osteoporotic bones, that'll cause a compression fracture.
And what's important in imaging at that stage also, again, which you look for specifically, is, in the elderly individual, just having compression fracture from osteoporosis, that's one reason. Right. But you can also have a compression fracture from having a tumor or even a metastasis in your spine. And the spine is a very common area for metastatic lesion from tumors, or things like multiple myeloma, which can originate in the spine as well. And that imaging can help differentiate on that as well.
Right. Yeah, and that's why it's with vertebroplasty, which is the procedure that helps the compression fracture. Sometimes if we have any suspicion, both clinically and by MRI, if there's a tumor, I can take a biopsy before I put the cement in and send that over to the lab to see, in fact, is this a metastatic process or a primary bone tumor process.
Yeah, and maybe we'll touch a little bit of compression fractures and vertebroplasty later on. But since we touch upon the injections, I think it's kind of a less invasive technique to help some back pain.
Right.
Can you maybe just describe, what do you do when a patient comes in? Specifically, you set up for the injection. They're going to have the injection. What is their experience? What will they expect?
Okay. Well, I'll do this in the second half as well with the slides. But basically, it depends. If they come in for a consultation first, I'll talk to them, I'll go over their MRI imaging, and of course I'll have your input as to what you think is going on, and then we put that together, and the patient comes in for the actual injection about a week or two later, and then we have the patient lie flat on a fluoroscopic unit on a table. I go to the level that we thought about that may be causing the problem, and then I inject under fluoroscopic guidance, under live x-ray, at that level, both a combination of the steroid and the bupivacaine, which is a longer lasting Novocaine. So that combination, or that cocktail, I'll put into that level, and the patient will have some transient, I'm talking about like maybe 20 seconds of what I often tell them before, you may get this lightning bolt going down your leg because we're in the right spot. The epidural space is innervated by all these nerves, so you may get that sudden jolt, but that's a sign, unfortunately, that's a good sign that we're in the right spot. It doesn't have to always happen, but especially if there's an inflamed nerve from a compression, with my experience with those, the patient will have that transient pain on the table, but I'm talking about 20 seconds. But I often tell them that 20 seconds of pain is going to give you months of relief. So that's basically in a nutshell what to expect from an epidural and what I tell the patients.
And it's ambulatory. They come in, they have the procedure, they're ready to go.
Right. Yeah.
And when would they expect, let's say, some relief? Is it immediate? Does you have to kind of wait a little bit on it?
Well, I often tell them anywhere from 2 to 10 days. They're going to feel better the first day because that Novocaine, that longer-lasting Novocaine called bupivacaine or Marcaine, will give you anesthesia or pain relief for a good 8 to 10 hours. Then I tell the patients you may get that lag where you may get the pain back for a couple of days because that wears off, and the steroid will start metabolizing and getting into the mode of helping you. So it takes anywhere from 2 to 10 days to get the full effects. And you're allowed 3 injections in a 6-month period because too much steroid, as you know, can have adverse effects. So even though it's not systemic, it's not in your blood system, you want to limit it to 3 in a 6-month period. So I often tell them, if in 2 weeks you're still not better, you may do well with another injection because it is a cumulative effect.
But you want to see at least some response maybe after the first one. Or it would
Yes.
be nice to have a response after the first one.
It would be nice, but sometimes in some patients it's difficult for that, and you would want to try a second one at least to get the cumulative effects of the steroid.
So that's sometimes how injection can even help some mechanical low back pain. And if you stay tuned, we'll go into a little bit more depth even about compression fractures. And I know Dr. Rico also has a presentation for us which will be very informative. Stay tuned. I'm Dr. Amit Lahav with Dr. Vito Rico. We'll be right back to Healthcare from the Hill.
Oh, you say you can't live without me now, but ain't that some shame?
Welcome back to Healthcare from the Hill. I'm Dr. Amit Lahav, and today with us we have Dr. Vito Rico, neuroradiologist, and we're discussing back pain. So let's jump right back into it, Dr. Rico. I know you got some presentation for us here.
Sure. So basically, my presentation that I often give to some local doctors and some committee meetings is managing back pain through neuroradiology. It's just a way of managing back pain by using imaging. So who can treat back pain or can manage it? Neuroradiologists like myself, anesthesiologists, sports medicine doctors can do it, neurosurgeons, of course, orthopedists, and physiatrists, which are rehab medicine doctors. They're MDs that can also treat back pain by doing physiatry or muscle count rehabilitation. So why a neuroradiologist? Like I mentioned in the first segment, it's one-stop shopping, I think. We know the imaging landmarks. We know, because we're anatomists in terms of imaging. We perform other kind of neuroimaging like myelograms, which is in dropping a contrast into the cerebral spinal fluid. And we can put together these imaging findings with the patient's symptoms to target the therapy. So what are some of the things we do? Well, vertebroplasty, like we mentioned, is for spinal compression fractures. Epidural steroid injections are for neck and lower back pain, and sometimes even thoracic or mid-back pain. Joint injections can be also performed. This is beyond the scope of neuroradiology, but I also performed image-guided shoulder, hip, wrist, ankle injections for both imaging to see what's going on inside the joint and for pain management. So we'll start off a little detail into vertebroplasty. So basically it's a surgical treatment for vertebral compression fractures, but it's really not invasive like a typical surgery is perceived like. We have to understand the significance of these fractures, the impact on society and the quality of life, who is a candidate, and do they get better from this? Here's a picture showing osteoporosis, how much bone loss there is in a vertebral body. So here's a healthy versus an osteoporotic one. You can see the bone loss on the right and the healthy one on the left. So spine fracture is a common manifestation of osteoporosis. So older women, usually older than 65 years old, 40–50% of them can get a fracture. 10 million people with osteoporosis, a big number. 18 million people with osteopenia, which is a less degree of the bone loss. 80% of these people are women. So here's some statistics. 1.2 million fractures, 700,000 of those are spinal fractures, 300,000 are hip fractures, and 200,000 are wrist fractures. Of course, these are all sort of estimated or rounded off. So what are the percentage of times, where is it going to occur? Usually in the age group 50 to 59, 7.6% is in the spine. Then over 80, about 32% of the time is going to be in the spine. 16.5% overall in the spine. When you have osteoporosis, you can see a fracture. This is just a graph showing the bone fracture threshold. Men and women, as you get older, you're more prone to get that fracture. They almost equalize when you get older for both men and women, even though it's more common in women earlier on. This is another curve showing the same thing, that men are a little less susceptible early on to these fractures, but they start meeting up with the women up later on in age. So this will worsen, unfortunately. There is an aging population worldwide. This will double in the U.S. It's estimated by 2040, and will quadruple by 2050. And research to date is on Caucasian women. And so a woman's risk of hip fractures is equal to her combined risk of breast, uterine, and ovarian cancer. $14 billion is spent annually on healthcare on this osteoporosis. And osteoporosis is the 12th leading cause of death in older women. I'll be more specific with that. The comorbidities of not being able to move, getting a DVT, getting a clot because you're not moving, infections, not moving your lungs appropriately, that causes a lot of comorbidities and comortalities with this. So no, directly the fracture won't cause a death, but the secondary effects of you lying in bed and getting a clot is pretty significant. So that's why we like to treat these. So this is associated with an estimated 13 to 18% increase in age-adjusted mortality. Disability, depression from lying in the bed with this fracture really adds up. Respiratory compromise, because you're not breathing right, you can't take a good deep breath. And this in effect leads to other things like GI disturbances. You can't move your bowels, you can't function properly. Or taking the medicines, the pain medicines for this stuff will give you GI constipation. So we want to get the patients off of this and get them helped. This is basically, it didn't come out great on this, but they're supposed to be spine dermatome distributions. When it's localized in the lower back, that red dot where it says yes, that's the fracture is localized. When it goes in an axial distribution across your back, like usually along the belt line or in a woman in the bra line, that's usually a pain distribution in vertebral compression fracture. Where that yellow little oval is, that's supposed to show radiculopathy or sciatica. That's usually not what you see with a compression fracture. That's what you see with a disc herniation. And again, the one on the right with the green, it says no. That's if the pain is going up and down the spine, it's usually not from a compression fracture. So it's localized or axial back pain. We start worrying, and with the patient history, that in fact they have a fracture. Here's a diagram showing what a fracture looks like. It looks like what we call vertebral planar or flattened vertebral bodies. This is really exaggerated, but that's what a fracture would look like extremely. So what kind of imaging can we do before to see this? Here's a bone scan, and that black dot in the middle of the lower back next to the kidneys is a fracture that lights up that's pretty acute. That's a bone scan that we inject a material to light up the bones. So we can start off with that, x-rays of course, and then MRI. Here you could see that on the right, that black-like image where the spinal cord is, the cerebral spinal fluid is, the white areas in the spine, in the middle of all that dark, are the compression fractures. Here are 3 pictures showing before and after, sort of. Here's the MRI. The MRI shows the compression fracture, that little wedge. The rest look like regular rectangles, but that one looks like a wedge.
On the left side.
On the left side. The one in the middle is a regular x-ray showing that compression. And here's the cement at the end, what my final product would be, with that white spot in the middle of that. Now you do have some height restoration, but mostly we're trying to decompress that fracture, give it some stability. It's like filling in a cracked tooth that the dentist would, or a filling. You want to stabilize that tooth or that fracture. So that's what we do. Here are two compression fractures on an x-ray, and it's hard to see the normal bones because these patients have what we call ghost bones because they don't have the normal trabeculae. They're washed out, kind of. So it's hard to see, but the rectangle in the middle is a normal vertebral body. The one above and below it are compressed. So we treat those. Here's a picture of the vertebral body and sort of like going from head to toe, kind of. And there's my needle coming in and the cement coming into the front of that vertebral body that's compressed. We square off the end plates. That's how I would do it on the x-ray. I do this on the x-ray, live x-ray called fluoroscopy. I square off the end plates to make sure they're all lined up. Then I take the needle, which is obviously the black thing that's a metal that the x-rays can't penetrate, so it shows up black. I put it down what's called the pedicle, that round circle. So we're going right into the vertebral body. Here it is end on, okay? So that's that needle end on. The two wings on it is what I use to turn. But the black dot in the middle is going down, what we call down the barrel, down into the vertebral body. Here's a side view. You could see that needle going into the compression fracture. Here's the final product. The cement is black because the x-ray can't penetrate it. It's actually coated with barium so we can see where we're going with it. Well, we could eliminate this slide.
Okay.
Epidural steroid injection. Okay, that's the next topic of discussion here. So the epidural steroid injection consultation. We consult for back. You know, I can be a consultant for the back pain if sometimes if it's an internist that wants to send it to me, or maybe the orthopedist wants to get my input into where the pain generator is. So I look at the MRI. I have the patient in the office. We have the patient be off of the blood. This is part of the consultation. We have the patient be off of blood thinners, Coumadin or aspirin for 5 to 7 days. Although those criteria are changing. It's performed as an outpatient service, and it's about a 10 to 20 minute procedure. I usually have the patient wait about 30 minutes after the procedure, make sure they're okay. Here are what I call tools of the trade, basically, to help me in diagnosing and treating. The image on the left, my left, is a MRI machine. It's an open MRI that we use primarily in my office for claustrophobic and bigger patients. And we get the imaging that way. And the image on the right shows the actual unit that I use to guide me to do the procedure, so a fluoroscopy C-arm unit. So epidural steroid injections, they help reduce inflammation. Inflammation can be from nerve compression. Both, like I said in the beginning, both uses a steroid and anesthetic, a depomedrol and bupivacaine. It takes 2 to 10 days for the full effect to start, and it may require 2 to 3 injections in 3 in a 6 month period. You can't really exceed that many because of the amount of steroid. Here's a diagram showing a side view of the actual spine with cutaways. So you can see the needle going into this little tiny space called the epidural space. It's going through the spinous processes, and the needle, what I use is called a loss of resistance technique, where I put air into a glass syringe, and as soon as I'm in that space, the air is released into that space, and I know I'm there. And I also performed an epidurogram where I inject a dye to make sure I'm in the right spot. I also do cervical. I know we're touching mostly on the lower back here, but I do cervical epidurals. They're a little bit more involved in that, it's closer to the base of the neck and the brain. So, you have to be extra careful, but they're very safe. I've done many of these. Usually associated with, cervical neck pain could be from neck pain, shoulder pain, arm pain. We get an MRI of the cervical spine. We often see a disc herniation. I usually want to inject that one spot, about C6, C7. That's different from the lumbar spine where you can go from L1 to L5, S1. You want to really stay about C5 or C6, C7, lower down. You don't want to go closer to the brain. I usually use Celestone, steroid only, no anesthetic in the cervical spine because of the proximity to the brain. And it starts working like the others in about 2 to 10 days. and may require 2 to 3 injections. This is just a funny slide showing the after effects of steroids and why we really don't want to. I mean, steroids, they came out in the 60s. They were a big benefit to JFK when he had his back pain, but then they soon started discovering, like anything else, too much good can be bad. So we don't use too much steroid. It's been performed for decades. It could be safe and effective, but there are some complications from using too much steroid. So that's why we like to limit it for 3 injections in a 6-month period. Here is an epiduragram on the right. That's the black. That's the dye that I put into the epidural space. And the image on the left is the, again, another C-arm that I use to guide me where to go using X-ray. Here's a cervical epidural, a very delicate procedure, but that little tiny wispy line on the left shows that I'm in the right spot. I'm not inside the actual canal, but I'm in the epidural space. So once I get those 2 images, I'm safe, I'm comfortable, then I inject the celestone inside that. You know, like this is just a little segue into other things we do. The orthopedist will sometimes refer us to do outside of the spine. We can do other injections into joint spaces. Hips, shoulders, knees, wrists, elbow. We mix, again, the steroid and the anesthetic, and we use fluoroscopy for accuracy. Here's an example of a shoulder. We're in the right shoulder here, and a 63-year-old female. She had what's called rotator cuff tear with impingement, and ortho suggested that we do an injection there. That's one thing I want to say. I mean, I don't just, they don't come in for consultation and I start saying, all right, get a shoulder injection. I always have the orthopedics refer this to me because they know the joints. They're specialized in this, and they tell us where they want injected. Usually, you know, the joint injections from my, not doing a real study, but my practice, I get from 3 to 6 months relief for the small joints for some reason, because I think it's a contained space and they get a lot of relief from this. Sacroplasty is something that's sort of still experimental mode. I could tell you that, you know, Medicare still doesn't even pay for this because they still consider it experimental, but I have to tell you from my experience, I think nationwide when I started doing these, only 5 were done. And now I'm not sure how many, like everything else, many more are being done. Even though they're really not still considered experimental stage and there's no real code for it, they do wonders for the patients. Patients, I've had 2 or 3, I can just come to mind, that have left their walkers because of this procedure. Especially they're putting cement into the lower sacrum, which we'll go to the image next. That's a sacral insufficiency fracture. That's the sacrum. The little yellow spot on the right is the sacrum. That's where they get fractures. The sacrum is a continuation of the lumbar spine. So older patients, much older, can get what's called a sacral insufficiency fractures, and I fill those in with cement as well. That's what a sacroplasty is. We do that on the CAT scan. Here's a CAT scan, the white spots of the cement. This patient, like I said, you used to use the walker before this and no longer needed the walker because we cemented that and gave her pain relief. Here's just some other examples. A 65-year-old female has some back pain. Here's an MRI. Here's a compression fracture. Here's the white spot. We helped that with cement. Here's the end product. Here's the cement inside the vertebral body on an X-ray. This is the epidural on a cervical spine, 43-year-old male. He was a construction worker, had a C6, C7 disc, that little arrow showing that black disc causing a narrowing of the spine there. The gray line is the spinal cord. So we helped that by coming in posteriorly in the back and the back of the neck and pouring in some of the steroid, which helped for about 6 months on this particular guy.
All right, actually, I wanted to maybe just touch again on the model. You talked about the sacrum. And the sacrum is actually where the pelvis meets. So if we can maybe zoom in a little bit on this. This is sort of a rear view of your spine. This is your spine coming down here. Again, the lumbar spine is your lower back here. And then it connects to the sacrum. And the sacrum, it actually connects to your pelvis. but there's still nerve roots coming out of the sacrum. You can get fractures that occur in this very low part of your spine, which doesn't have the mobility or the motion like your lumbar spine above, but compression type of fractures or sacral insufficiency fractures can occur really in this region here. And that's what Dr. Rico was speaking about. It's a very low, essentially back pain. It's more towards really your buttocks or really into your butt crack, really, which can be treated as Dr. Rico referred to. But that's really the difference where the sacrum is and the lumbar spine here. And another thing I want to just indicate is really your lumbar spine, which really consists of 5 levels, L5, L2, L3, L4, L1, 2, 3, 4, and 5. The reason you get more of the compression fractures here, and the problem here, is because above it, the thoracic spine has the ribs attached. And the ribs give you some stability for that mid-back, which is why you don't really see as much mid-back pain. It's more of really low back pain or upper neck pain. And that's really important to consider also when somebody presents to you really with more of a mid-back pain. That's can be a different type of animal because it's a different thought process in there because it's a more stable part of your back because you have the rib cage there. But most of your mobility for the back actually comes from your lower back, your lumbar spine, as well as your neck as well, which is why I think you see more of the injuries in that area. Also consistent with motor vehicle accidents as well. It's usually neck pain or low back pain. And that's also important when you have kids to have really the proper seats, because the seat belts have to hold the kids in the proper position, because when there is an accident, they can sort of pivot at the wrong level and cause pretty significant injuries accordingly. So just touching on really the pediatric population with back pain. So really overall, I just want to emphasize, the back pain is very common. And most back pain is more mechanical back pain or strain. And really doing proper exercises and sometimes even physical therapy with some anti-inflammatory medication, being flexible, is very important. It can really treat most of the back pain. And hopefully if you maintain just a program of certain exercise, which I actually give to patients to even do on their own, along with sometimes use of heat, lumbar corset for stability, especially if you're doing a lot of lifting, pulling, pushing. You want to sort of distribute the load a little bit better, so a lumbar sort of brace or corset can be helpful. That's really how we treat most of the back pain, but more of that sort of persistent back pain, sometimes along with a disc herniation, spinal stenosis, facet type of pain, and even trigger point type of pain. We do refer to individuals like Dr. Vito Rico, neuroradiologist, which can really give a big difference by just giving this injection and can really help you. And I want to emphasize also, I have a lot of patients ask about these injections. The injection doesn't go into your spinal cord and doesn't go into your spinal root. It goes around it, and it doesn't go particularly into your bone either. Compression fractures is a different phenomenon, but I'm talking just the steroid injections. So understanding that and all the different options we have to work with back pain, and most of it will get back better really on its own, you got to give it a chance and treat the appropriate diagnosis. So I'd like to thank Dr. Rico for being here today. Stay tuned, and we'll be just recapping today's back pain. Thank you, Dr. Rico. You're welcome.
We don't do that kind of show.
Welcome back to Healthcare from the Hill. I'm Dr. Amit Lahav, and we've had today with us here Dr. Vito Rico, neuroradiologist, and we spoke about back pain. And again, showing your lower back, it's your lumbar spine, right before you hit your sacrum, which articulates with your pelvis. And this is where you have most of your back pain. And We've discussed mechanical or low back pain and strain, different procedures we can do to help you with the pain, and that includes, Dr. Rico, things like injections. But there's also physical therapy, anti-inflammatory medication, muscle relaxant that we use as well. We sort of left aside some of the surgical reasons that have to be performed for different type of back pain like disc herniation and severe slippage like spondylolisthesis, because I want to emphasize really most of the back pain tends to be mechanical or a strain, and sometimes spinal stenosis or narrowing. And a lot of time this type of back pain can be treated conservatively, which means you don't need any major type of procedures. Again, another exception is the compression fractures, which Dr. Rico discussed, which there are some treatments that can be done, a little bit more invasive, but generally in and out type of procedures, which can provide you also relief. So that's an overview of back pain. Thank you for watching Healthcare from the Hill. I'm Dr. Amit Lahav, and we'll see you next time on Healthcare from the Hill.